First of all, welcome to country. The Royal Australasian College of Surgeons acknowledges the traditional owners of country throughout Australia and recognises their continuing connection to land, waters and community. And we pay our respects to them and their cultures and to elders both past and present. I'd like to welcome all the speakers. I'm Matthew Hadfield. I'm chair of the Victorian State Committee. We have 3 judges tonight. We have Patrick Lowe, Amy Tousell and Marilyn Raj, who have muted and disappeared from the screen at the moment, but will be listening intently. We're going to keep pretty much to time because it's a fairly packed schedule. The first speaker tonight, speaker number 1, is Wilson Yang. So Wilson, if you can unmute yourself, turn your video on, and your time starts now.
Just to confirm, can everyone see the screen that I'm sharing?
Yeah, go.
Thank you. Thank you for the kind introduction. Good evening, everyone. I'm Wilson, one of the unaccredited general surgical registrars at the Alfred, and I'm grateful to be given the opportunity to present here. My study is titled Non-Operative Management for Small Bowel Obstruction in the Virgin Abdomen, a Systematic Review. Before I begin, I also wish to state that I'm the primary researcher for the study, and I declare no conflicts of interest. Small bowel obstruction is a common general surgical presentation which accounts for at least 12% of surgical admissions and more than 300,000 operations annually. Traditional surgical teaching decrees that one should never let the sun rise or set in a small bowel obstruction. Over time, there has been a gradual shift in its management from definite operative intervention to a more conservative approach. Conventionally, explorative surgery has been advocated in patients with a virgin abdomen due to concerns regarding malignancy or an obstructing lesion. However, there is increasing evidence showing that a subset of these patients can be treated conservatively. Hence, we perform a systematic review to assess if non-operative management can be a safe and feasible option in patients with small bowel obstruction and a virgin abdomen. Our secondary aims were to compare associated mortality and morbidity rates and identify its etiologies in this group of patients. Our systematic review was performed in accordance to the PRISMA guidelines as shown in this figure. We identified relevant studies between 1995 and 2020 using the keywords virgin abdomen and or small bowel obstruction. From our initial search, there were 44 papers and it was cut down to 6 papers. The 6 included studies are shown in this table. All the studies were retrospective observational case series, including one which utilized a prospectively collected database. All studies scored 6 or more on the Newcastle-Ottawa scale and therefore were deemed good quality studies. The modality of non-operative management were varied, with the most consistent approach keeping the patient new by mouth with gradual diet upgrade. Nasogastric tube insertion for the purpose of decompression was used in 4 studies, and 2 studies utilized the gastrograph and oral contrast agent approach. Amongst a total of 416 patients, 205 or 49.3% had non-operative management, and 211 or 51.7% underwent explorative surgery. In the non-operative group, 196 patients or 95.6% were successfully treated, and the remaining 9 patients failed conservative management and required surgery. In the explorative surgery group, 187 patients or 88.6% were successfully treated. The remaining 24 patients had a negative explorative surgery, meaning that nothing unusual was found and therefore nothing was done intraoperatively. Within the non-operative management group, 3 out of 96 patients or 3% suffered from aspiration pneumonia, and in the explorative surgery group, 13 out of 50 patients or 26% suffered from both aspiration pneumonia and superficial surgical site infections. In regards to mortality rates, both groups had 0 fatalities reported. The commonest etiologies of small bowel obstruction in the virgin abdomen were adhesions at 63%, malignancy at 11%, foreign body of the zoa at 5%, or internal hernia and volvulus both at 4% each. Other causes included inflammation, gallstone ileus, and Meckel's diverticulum. As mentioned in the previous slide, a high success rate of non-operative management is possible because the predominant etiology of small bowel obstruction in this group is adhesions, accounting for 63% in our study. Adhesions may be congenital or may have developed as a result of previous intra-abdominal infections. Furthermore, with the wide availability of CT scans nowadays, such patients can be stratified appropriately by detecting other non-adhesional intra-abdominal pathologies. Not surprisingly, we found that the CT scan is highly utilized, ranging from 93.5% to 100% across the studies. From our findings, we recommend non-operative management in a select group of patients, with exclusion based on criteria presented here in this table. It is imperative to recognize that operative management is still necessary in patients with hemodynamic instability, clinical features of peritonism, incarcerated hernia, closed loop obstruction, or obstructing tumor. These cases have a high index of suspicion of bowel strangulation, which may lead to ischemia, necrosis, or perforation. Emergency operative intervention should not be delayed in these patients, as the consequence will be catastrophic. There are a few limitations identified in this study. Firstly, there was significant outcome measure heterogeneity amongst these studies, which made data summation by a meta-analysis not possible. Secondly, the small number of papers identified in this review, in which all were non-randomized and retrospective in design with their inherent bias. In conclusion, non-operative management for small bowel obstruction is a safe and feasible option in patients with a virgin abdomen. Patients should be carefully selected for this management protocol. Adhesions are the most common cause of small bowel obstruction in this group of patients. Looking ahead, further large-scale prospective clinical studies with standardized management modality, homogeneous clinical resolution indicators, and long-term follow-up data are warranted to allow for quantitative analysis to reinforce this evidence. Here are my references. And thank you.
Thank you, Wilson. I think the judges are probably here. Have we got 2 minutes of any questions for Wilson about his presentation? Wilson, now it seems from a big literature search on a very common topic that's a fairly limited haul of papers that eventually were included. You only had 6 studies for one of the commonest surgical presentations. How's that influenced your results?
So unfortunately, during the literature search, most of the papers that were found were in patients who had previous abdominal surgeries, and there were not too many data available regarding a virgin abdomen and small bowel obstruction. Hence, although the results that we have found is quite reassuring that we can manage such patients in non-operative measures, we still need further large-scale clinical trials in order to further reinforce this statement.
Okay.
Wilson, I've got a question. Marilyn Raj here. You reached the conclusion that in the virgin abdomen, non-operative management was reasonable because the majority cause is adhesions. What about the perspective that if these patients have an adhesion, they're likely to represent with another bowel obstruction? Doesn't that mean that there is an inevitable delay in dealing with the actual problem by non-operatively managing them? What's your thoughts on that?
Thank you for your question. I think that's a very, very valid point. In fact, 2 of the studies that were included in this systematic review did comment that the patients, which we've included as patients who failed non-operative management, did eventually get readmitted to the hospital and had eventual surgery to release those adhesions. So I think you're absolutely right in saying that there's a chance that these patients might represent at a later date. However, there's no data out there that confirms these numbers. But I do agree with you that it might mean that they may have a delayed presentation.
Okay, thanks, Wilson. Could you stop sharing your screen? That's great, and thank you. That's the end of the 8 minutes. So the third speaker, Humaira Haider Mahin, are you here? You ready to go? Hoping. Humaira?
Yep.
Okay, your time starts as soon as you start. Thank you.
Just confirming everyone is seeing my screen clearly.
Yeah, that's clear.
Yeah, okay. Thank you all for giving me the opportunity to present our study on Australian pedestrian injuries, demography, injury profile, burden, and burden. This is Humaira from Wollongong Hospital, New South Wales. Around 1.35 million road traffic deaths occur annually on the world's road, which is the leading cause of death for younger people, age range between 5 to 29. This is from the Global Status Report on Road Safety 2018. Nearly a quarter of these are pedestrian. Pedestrians are the most vulnerable road users. The aim of this study is to describe current epidemiology of pedestrian trauma across Australia. We'll be using data from Australia-New Zealand Trauma Registry. Australia-New Zealand Trauma Registry was developed as a part of Australian Trauma Quality Improvement Program as a collaboration of 26 major trauma centers in Australia. This registry started data collecting from 2013. Now, for our study, we extracted 4 years of data from July 2015 to June 2019. We extracted the data on patients' demographic, injury details, event, injury extent, fatalities, the discharge information, and then their blood alcohol level. We used descriptive statistics for our data analysis. We found there were 2,159 severely injured pedestrians over this period who were treated in 24 major trauma centers across Australia. This slide shows the basic characteristics of severely injured pedestrians across Australia, where the median age of those pedestrians are 47. Maximum injuries, intent or unintentional or accident, 95% cases. Injured pedestrians arrive through the healthcare facilities, 83.1% cases via road ambulance. 34.3% were intubated at arrival. 29% of them needed ICU admission. And most of the pedestrians sustained head injuries, and the number is 42.2%. This slide is showing the demographic profile, which is showing male pedestrians or 1.5 times more injured than the female. Young adult, age group ranging from 17 to 54, and elderly pedestrian aged over 74 were the mostly common injured population. Thursday and Friday remain the predominant days for severe pedestrian injuries over these last 5 years. Lowest number of pedestrian injuries occur on Sunday. Street or highway was the most common place for severe pedestrian injuries. 84.9% of total pedestrian trauma happened here. 6.3% pedestrian trauma occurred at home. 99.9% of severe pedestrian trauma injuries were resulted from blunt trauma. We found in 1,425 cases, the cause of the trauma was collision with car, pickup truck, or van. Most pedestrians who had the injury, the prevalent group were head and other non-major associated injuries, which is followed by multiple body region injuries in 38%. The age group above 75 had isolated head injuries, more, and the age group between 17 to 25 population sustained serious spinal cord injuries. Most pedestrians who require hospital admission after a severe trauma, mostly their injury severity score we found in the group 16 to 24, which is followed by another injury severity score group 41 to 75. 83.1% severely injured pedestrians were transported directly from scene to definite care via road ambulance. 8.8% pedestrians were taken via helicopter. 1.8% via private public walking, and only 0.6% needed a interstate transfer. The average hospital length of stay was 9.79 days, and average ICU length was 1 day. 19.4% pedestrians with severe injuries died in hospital, with 2% of those deaths occurred in emergency department. In 2019, we lost 160 pedestrians on road. Of those who survived to discharge, 42.9% were discharged home, 31.2% to the rehabilitation. Nearly 1,700 pedestrians who were severely injured didn't have a recorded blood alcohol level. We are still waiting from ATR to get more data on their comorbidity score and few other variables. There are few limitations on ATR data, particularly on missing blood alcohol data, more details information, place of injuries. And this study will be the first reported comparison of injury outcome in pedestrian trauma across Australia. And these analyses foster national cooperation to drive improvement in trauma, particularly pedestrian trauma. These are my references, and thank you all to join with me to stop accidents before they stop us. Thank you.
Thank you very much for that. If you could just stop sharing your screen, that's great. I'm interested to know why you think Thursday and Friday are the most dangerous days of the week.
Yeah, that'd be interesting to see when we get the whole result, when we receive the whole result, that would then would be easy for us to analyze. We're still waiting to get the full length of data from ATR.
Mm-hmm. Have you any theories why Thursday and Friday are worse for pedestrians?
Not really. We are still waiting, but and I think that is out of the scope of my study at this point. We are mainly locating on the demographic.
Marilyn?
Hey, thank you very much for that presentation. My question is directed at what sorts of recommendations would you feel should be considered to reduce the morbidity of pedestrian trauma? You've presented some, fairly compelling data here about this. So at this early stage, what areas in particular do you think as a community we need to address to try and, help reduce the numbers?
Sure. Thank you, Marjan, for this question. So we also looking at some other published data, particularly to those countries who are like globally leader on this reduced trauma, particularly Sweden, Norway, who have the mortality rate like only 2.5 or 2.6 per 100,000 per year. So we will be following them, particularly implementing on their policy like Vision Zero would be the #1 thing to apply, where they are working on the speed limit, working more on the street reconstruction, separating the pedestrian walkway completely from the motorway, putting more. There are a few more. I think that will come up when we finish our study and then finish our comparison.
Thank you.
Just one more question. I
Yes,
noticed there was a lot of work on blood alcohol level, but nothing on distracted driving and distracted pedestrians with things like mobile phone use.
Yes.
I appreciate it's out of the scope of your study. Is that something for future studies?
Yes, this is a very good point. I mean, because as I put on my limitation thing, the ATR data limitation, they didn't comment particularly anything on pedestrian behavior or driver's behavior, because those could be very important points or very important factors leading this pedestrian death or trauma.
Mara, I've got one more question.
Yeah.
Did you look? Thank you for that good talk. Did you look into detail about rural and metropolitan?
Yes, that's also a limitation. They just put a place of injuries, but they did not put a place of injuries, whether it is the remoteness was, how remote the injury was, how regional was that. So that was limitation. So these are the limitations that we found when we are doing this data analysis from ATR. But they should implement, or they should identify that regional or remoteness of the accident.
Thank you.
Thank you.
Okay, Humara, thank you very much for that. That was great. Maybe you can. We'll move on to the fourth speaker, which should be Jess Vo, who should be ready. Jess, are you ready?
I think Jess is not arrived.
In that case, we'll move on to the next speaker, which would be Jessie Nelipudi. I did see that name on the screen. Are you ready, Jessie?
Thanks, guys. Yep.
Good. Okay.
All right. Thank you so much. Can you guys hear me? Sorry.
Yeah, you're good.
Okay. Thank you so much for giving me the opportunity to present here. Today, the topic of my presentation is disparity in the incidence of pneumonia after cardiac surgery between Indigenous and non-Indigenous people. We have nothing to disclose. To introduce the topic, there's an increased prevalence of both coronary artery disease and rheumatic heart disease in Indigenous people. This is attributed partly to behavioral risk factors such as excessive smoking and alcohol intake, and also lifestyle factors such as educational disadvantage and poverty. Also, Indigenous patients living in non-urban or rural communities are at a disadvantage due to lack of fundamental healthcare resources. As such, they present 20 years younger for cardiac surgery. Especially in Indigenous patients, a collaborative approach is very important, and over the last few years, we've worked very hard to establish an extensive network, particularly with Northern Territory Indigenous patients, where they have dedicated care coordinators, multidisciplinary meetings via video conferences, and also dedicated Aboriginal liaison officers to improve health outcomes. And one of the important things we've noticed is that pneumonia rates were much higher in Indigenous patients. Patients undergoing cardiac surgery have higher susceptibility to pneumonia due to various reasons, such as hospitalizations before the operation predisposing them to HAPS, or common risk factors they all share, such as COPD, smoking, and alcohol intake. Also, prolonged ventilation and sternotomy and the associated pain with it affects mechanics of breathing and prevent them from taking deep breaths and predisposes to atelectasis and developing pneumonia. So the main aim of this talk is to identify the incidence of pneumonia between Indigenous and non-Indigenous patients over a 10-year period, to assess any difference in microbiology, and also to highlight the importance in collaboration, particularly for Indigenous patients in surgery. This is a retrospective observational study from a prospectively collected database, and a p-value of less than 0.05 was considered significant. In terms of patient characteristics, 18% of our population over a 10-year period was Indigenous, and they presented a median 20 years younger for cardiac surgery, and majority of them were male in both groups. Moving on to procedural characteristics, majority of the patients in both groups either had isolated coronary artery grafting or isolated valves, either aortic or mitral. There was a small difference in total procedure time and total bypass time, and Indigenous patients had a slightly longer ICU hours compared to non-Indigenous patients. in terms of risk factors, indigenous patients had a slightly lower BMI, but they had a higher prevalence of diabetes, renal disease, undergo a redo procedure, significant history of smoking and alcohol intake, and they also had a slightly higher mechanical ventilation time. So I guess the pneumonia rates, there was a significant difference in the incidence of pneumonia between these two groups. Indigenous patients had a recorded 22% compared to 12% with a p-value of less than 0.001. Moving on to microbiology, this was quite interesting. The indigenous patients in blue and the non-indigenous in orange. Indigenous patients had a higher prevalence of Haemophilus and Pseudomonas particularly, whereas non-indigenous patients had a spread of other gram-negative bacteria in their cultures, either sputum or tracheal aspirates. Moving on to discussion, indigenous patients in general have a higher incidence of respiratory disease. They have a high incidence of pneumonia, and this is associated partly due to behavioral risk factors that I discussed before, such as smoking and also alcohol intake. And they are 2.4 times more likely to be hospitalized for acute medical care from respiratory disease. And this is also associated with higher mortality for indigenous patients. So what this all means is that they have a higher prevalence of risk factors for pneumonia. So it's not surprising that they also have a higher incidence of pneumonia after cardiac surgery. And an important thing we've noticed is the prevalence of Haemophilus cultured in indigenous patients. Indigenous patients have a higher rate of invasive Haemophilus disease, and they also have a high nasopharyngeal carriage of Haemophilus despite having high rates of vaccinations. And this led to the idea that maybe indigenous patients have a higher susceptibility to influenza, and also maybe a genetic component is also involved. So therefore, at the moment, we're considering changing our preoperative antibiotic prophylaxis for indigenous patients and including maybe ceftriaxone as part of that to cover for this. A take-home message is indigenous patients have a higher prevalence of risk factors, and as such, they have a higher incidence of pneumonia after cardiac surgery. And collaboration is crucial, particularly to improve health outcomes for indigenous patients at a primary healthcare setting to minimize risk factors such as smoking and alcohol intake. Thank you.
Okay, thanks very much for that. If you could just unshare your screen. Amy, you got a question?
Jesse, was the different outcomes between different states?
No, so we primarily operate on Northern Territory patients, and it's all SA patients that we do non-Indigenous.
Yeah.
So a lot of our Indigenous patients come from Northern Territory and also rural South Australia. So Alice Springs and Mount Gambier.
Okay. Yeah.
And,
so was there any variation in areas, or were there very similar bacterial profiles between all Indigenous Australians?
Yeah. So a large portion of them are all from NT. So I think our numbers were too small to see if there was any difference between, Alice Springs, Mount Gambier, or Northern Territory. Like staggering, I think about 15 or 16% were actually from Northern Territory.
Yeah.
So I think it's hard to make that comment, but I think they do share a similar kind of profile.
Okay, thanks. Any other questions? Patrick or Marilyn, you got a question? I'm interested in, I mean, you commented particularly in your abstract as well about addressing the modifiable risk factors in the indigenous populations. It's hard enough addressing that in the non-indigenous population.
Yeah.
What are you proposing there?
Well, I think, I was highlighting to the smoking and alcohol, and I think that's something that we really need to work on, and we have been here. It is hard, you're right, but we have established a good relationship with the Northern Territory doctors. You know, I'm regularly in touch with some of the GPs there as well who work in rural, remote communities. And I guess that's what we really should try focus on, because, you know, we see them for such a short time, but majority of them, you know, this problem is persistent even when they go back. And we often see them represent as well because of, you know, ongoing issues with non-compliance, with medication, ongoing issues with smoking and alcohol intake. And I guess we just have to keep trying with working with the doctors there and the doctors in NT and keep reinforcing them. One of the things that really worked with us is the Aboriginal Health Liaison Officers. They're dedicated to Indigenous patients who have cardiac surgery, and for some, you know, they have much better rapport with them, and you know, they do listen to them, I guess, better than they listen to me sometimes. So.
Okay. Yep.
Sorry, just Jessie, one quick question. Thanks very much for the presentation. Do you have any preoperative programs that you've put together, given that you've identified sort of so many preoperative risk factors that need to be either modified or, you know, remedied?
Yep.
And have any of those programs achieved an effect that you've noticed?
Yep, so we certainly have, because this has been, you know, we've been working on this for many years now. So as soon as someone gets referred from Northern Territory, there's a dedicated care coordinator in NT and also a care coordinator in South Australia that manage preoperative workup and counselling and care. In terms of, you know, the fundamental primary risk factor like smoking and alcohol, I think that's very difficult because by the time they come to us, it's probably already too late, and that's something we're working on with the GPs now. But in terms of counseling them for surgery and you know, kind of educating them better on surgery and medication compliance, I think having those dedicated officers and care coordinators made a huge difference, because they just have a better way of communicating with them and also have that trust that I sometimes find that Indigenous patients don't have with us when they come here, because to them we are foreign. Whereas if you have a dedicated Indigenous patient talking to them saying you need to take warfarin, for example, because it's very important after valve surgery, it's a bit more effective than what we're doing. So I guess, you know, we will continue to work on the primary prevention stuff, but definitely from a medication compliance and post-operative care point of view, that has made a big difference.
Okay, thanks very much. That was great. Thank you. The next speaker is Patrick Liu. Patrick, are you there?
Yep. Hey.
Ready to go when you are.
All right, so good evening, everyone. My name is Patrick. I'm a final year medical student from Monash University. Haven't done MOOC myself, but today I'll be speaking about the reduced health-related quality of life in necrotizing soft tissue infection survivors. So necrotizing soft tissue infections are severe bacterial infections that affect the deeper soft tissue, namely the fascia and the muscle, and they're rapidly progressing and life-threatening diseases. The mainstay of their treatment involves immediate and aggressive surgical debridement, which often leaves patients with large wounds that require complex reconstructions and can result in disfiguring scars. Over the last few years, we've noticed a trend towards declining mortality rates for necrotizing soft tissue infections, which means that nowadays there are more survivors from NSTIs than ever before. However, little is actually known about the long-term outcomes of these survivors, particularly within Australia. So we designed a study to assess the health-related quality of life of NSTI survivors, and we measured two primary outcomes. The first was the Medical Outcomes Questionnaire, short form 36, also known as the SF36. This is a 36-item survey which assesses patients' health-related quality of life across 8 domains, and they can be broadly categorised into a physical component score as well as a mental component score, which provide an overall picture of a patient's physical and mental health-related quality of life. We also measured the Derriford Appearance Scale, also known as the DAS-24. This is a 24-item survey looking at whether patients have any distress and dysfunction regarding their appearance. So we recruited patients over a 6-year period from 2019 to 2013 to 19, including any patient who had a proven NSTI over the age of 18. And we invited them to complete these 2 surveys. We had 61 eligible participants and 30 respondents, which resulted in just under a 50% response rate. And the median time from NSTI to survey completion was 27 months, so just over 2 years. The mean age of our cohort was 54, the majority of them were male. The mean percent total body surface area debrided was 4.5%. 2 patients required amputations, and the mean length of ICU stay was 6.5 days. Mean length of hospital stay was 31 days. So we first looked at the SF36 scores, and this graph shows the NSTI cohort in blue with the Australian normative population in orange. And as you can see, the NSTI cohort reported a 27% reduction in their physical component score and an 11% reduction in their mental component score. And these both were statistically significant results. So this shows that NSTI patients have a significantly reduced physical and mental health-related quality of life compared to the average Australian. Now, you might expect this from someone who's been through an acute injury like an NSTI. However, when you look at burns patients who are quite similar to NSTI patients in terms of the pathology and their treatment, burns patients by about 18 months actually report similar SF36 scores compared to a comparative normal population. So this shows that NSTI patients have quite a significant burden of disease, and their SF36 scores are actually quite similar to many chronic disease patient groups, such as stroke and end-stage renal failure patients on hemodialysis. When we looked at the DAS24 scores, we found that the NSTI cohort reported a 25% higher DAS24 score compared to a non-clinical population. So these were people who didn't have any pathology affecting their appearance. And a higher DAS24 score indicates more dysfunction and distress regarding appearance. So we next wanted to look at whether there were any factors associated with these SF36 scores to see if there were any potential targets for any quality of life interventions. So we looked at demographic features, NSTI-specific features, the method of reconstruction, and general hospital stay features. And we only found that age and DAS24 score were significantly associated with physical component score. And there was an inverse correlation. So the older the patient was and the more distress they exhibited regarding their appearance, the lower their physical health-related quality of life. Similarly, with mental component score, the higher the DAS24 score, the lower the mental health-related quality of life. So overall, our study shows that NSTI survivors have an ongoing and significant burden of disease following their acute injury. We found that many of the objective markers of severity of disease were in fact not associated with quality of life. Rather, the subjective factors, such as the DAS24 score, were, and this presents as a potential target for quality of life interventions. So there have been several studies among burns patients that show that psychological therapy can in fact improve DAS24 score, and this may potentially improve health-related quality of life. In fact, NSTI patients are a relatively forgotten group of patients compared to burns patients. They don't receive the same level of physical therapy and psychological therapy following the acute injury. And I think this ties back into the theme of this year's conference of collaboration in surgery. The job isn't necessarily done with the acute treatment of NSTI patients. In fact, it's only just beginning, and perhaps we should be looking more towards the long-term outcomes of these patients. And this is where we may need to look towards our allied health colleagues for their expertise. So thanks very much for your time. I'm happy to take any questions.
Thanks, that was really interesting. Thank you. Has anyone got a question?
Patrick, Marilyn Raji, thanks for the presentation. My question is directed at your conclusion about the morbidity perspective. One of the risk factors for patients presenting with this problem is significant comorbid disease such as diabetes and obesity. What roles do you think their morbid status plays on their perception of body image post-surgery, Could you comment on that, please?
Yeah, definitely. So we did look at whether those comorbidities had any impact on their SF36 score, so their score relating to their quality of life. And we found that there was no correlation. I do think that with quality of life indicators, there have been a lot of studies that show that actually the objective markers of how a person is and the objective severity of their disease actually doesn't correlate very well with quality of life, but subjective factors do. So things like diabetes and smoking might not actually affect if a patient is able to adjust to those premorbid conditions prior to their acute injury and just generally, then they will probably be better suited to better able to adjust to the insult of a necrotizing soft tissue infection. So I think it's very much the psychological side, psychosocial side of this, as opposed to the actual physical and pathological side of these diseases.
Yeah, I've got a quick question. Patrick, thank you for a great talk. Did you look into their pre-morbid psychological state? Is there any comment about their pre-injury, pre-illness status?
That's a good question. Unfortunately, we didn't have the data relating to that. We didn't know if any of the patients had psychological disease beforehand, such as depression or anxiety. There have been a few studies among burns patients that show that burns patients are more likely to develop psychological distress following the injury, such as PTSD and things like that. So whilst it might not exist prior to the acute injury of an STI, it could probably be a result of that as well. So I think they would still benefit from psychological therapy.
Okay, thanks very much, Patrick, and thanks for a great talk. Okay, the next person on my list, the next speaker would be Christopher Steen. Christopher, are you there?
Yeah, hi there. Can you hear me?
I can hear you, and I can see your presentation as well.
But
whenever you're ready.
All right, just bear with me. Can you see my presentation there?
Yeah, that's good.
Okay, thanks very much, Dr. Hadfield. Good evening, everybody. My name is Christopher. I'm one of the registrars at Box Hill, Eastern Health in Victoria. And on behalf of me and my study collaborators, we greatly appreciate the opportunity to present a recent randomized control trial that we carried out at Eastern Health. And that was local anesthetic for pain post-rubber band ligation of hemorrhoids. So this was an RCT that was done in conjunction with my master's project through the University of Edinburgh. And getting right into it, rubber band ligation, or RBL, is a safe, simple, and economical treatment for hemorrhoids. And we know that pain following an RBL is a common complaint from many of our patients. Certainly, if one looks at the literature, anywhere from 25 to 50% of patients undergoing RBL will report some sort of pain. And several RCTs have addressed this by looking at comparing the use of local anesthetic in an RBL versus no local anesthetic at all. And the methods and the results of these studies are varied. Additionally, there is limited research on the impact of local anesthetic with respect to oral analgesia consumption. So we sought to primarily establish if the adjunct of local anesthetic injected into the base of the ligated hemorrhoid would reduce early postoperative pain experienced by the subjects. Additionally, we examined perianal numbness. Now, this was a new variable that we felt warranted investigation, given the plethora of literature that discusses the effects of anorectal procedures on the nearby pudendal nerve supply with respect to such things as adverse events. And adverse events we also looked at in this study. And lastly, we sought to establish if there was any difference in oral analgesia consumption by subjects. So this was a prospective single-blinded RCT. It was ran through 2 centers in our health network. Subjects were identified in the colorectal outpatient clinics. Anybody who was deemed suitable for an RBL in conjunction with an endoscopic procedure was recruited into the study, and a computer-based program randomly assigned patients into the control group, which was no local anesthetic, and the intervention group, which was the local anesthetic. Now, in terms of our primary outcome, that was pain. So we looked at the mean pain scores measured using a standardized and validated visual analog scale. And this was measured at multiple time points, being 1 hour, 4 hour, 24 hours, and 48 hours after the RBL was carried out. Secondary outcomes were recorded dichotomously as either a yes or a no, with the exception of oral analgesia, for which we also recorded the amount taken or used. Now, with 60 subjects enrolled in the study, there were no significant differences between the age, the gender, the weight of the patients, their BMI, the mean number of hemorrhoids ligated, or the grades of the hemorrhoids reported. And displayed here is the results of our primary outcome, which is the mean pain scores over time. You can see the time intervals there at 1 hour, 4 hours, 24, and 48 hours. And in the blue, you can see the intervention group, and in the red, you can see the control group. The results demonstrate that at the 1 hour post-procedure time point, the pain scores were significantly lower in the intervention group compared to that of the control group. However, at no other time point was there a significant difference between the two groups. Additionally, you can see that the pain in the control group reaches its peak at 4 hours and then takes a steady decline. Whereas interestingly, in the intervention group, you can see after 1 hour, a sharp rise before it finally peaks at the 24-hour mark and then declines. I suspect that's because that's when there's a sort of a rebound effect when the local anesthetic itself is wearing off. At no time point in this study was there also a significant difference between perceived perianal numbness between the two groups. Additionally, subjects in both groups were equally as likely to consume oral analgesia, and there was no difference in the amounts consumed with respect to paracetamol, ibuprofen, or any opioids. Furthermore, there were no significant differences between any subject-reported adverse events. These are the adverse events we were looking at, which was bleeding, swelling, incontinence, urinary retention, etc., with postoperative bleeding being the largest event reported overall. But importantly, no patients in either group reported any worrying adverse events or complications during follow-up that required us to admit them for further observation or intervention. So just to wrap it all up, the fact that there was a significant reduction in pain 1 hour after local anesthetic and that it was a well-tolerated intervention suggests that surgeons should consider the use of local anesthetic when performing a rubber band ligation. That being said, patients should be forewarned about a possible rebound effect and prescribed analgesia accordingly. Where I would like to see this go, I'd like to look at the role of aperients in help reducing postoperative pain as an adjunct to local anesthetic, other methods of providing pain relief, such as suppositories, or any long-term differences in hemorrhoidal treatment success. Specifically, I'd like to look at patient satisfaction to see if patients were better off with the intervention group. I think I'm probably out of time, so I'd like to thank you all for taking the time to listen to me. Those are my references there, and I'm happy to open it up to questions now.
Okay, thanks very much. Has someone got a question? I'll open it up to my three fellow judges first.
Christopher, thanks for that presentation. So you look particularly at rubber band ligation. It appears that your research is showing that local analgesia seems to be preferred to systemic analgesia in these types of cases. Have you come across any other similar procedures where you have noted that patients seem to be well controlled with just local regional anesthesia or analgesia, beg your pardon? Could you comment?
Well, that's interesting. Like, even with respect to rubber band ligation, we know that intraoperatively, patients undergoing an endoscopic procedure, such as a colonoscopy with the rubber band ligation, will actually, if they receive local anesthetic, they'll actually have less intraoperative analgesia given by the anesthetist per se, and that their follow-up in recovery also reports less pain scores. Does that sort of help? I know it's not a different procedure, but using that also reduces the amount of adjunct intravenous analgesia given by the anesthetist. And certainly some studies have looked at this in the past, many years ago, where rubber band ligation was carried out in the rooms. We don't do rubber band ligations in the room at my network anymore, but they also found similar results. However, those would be difficult to do blinding because obviously those would all just be local anesthetic. There would be no additional sedation or anything like that. But patients would be privy to if they were being injected by a local anesthetic whilst having RBL done in the rooms.
Thanks.
No problem. Thank you.
Any other questions? We've got time for one more if anyone's got one. I'm interested, Christopher, because traditionally the cause for severe immediate pain in rubber band ligation was that you take some of the skin rather than purely taking the mucosa into the rubber band, and that's what causes it. So I could argue that by using local anesthetic, all you're doing is countering poor technique at rubber band ligation. Is that a reasonable conclusion?
Correct. Yeah, correct. But I mean, all of our rubber band ligation being carried out was under direct vision to make sure it was above the dentate line.
Mm-hmm.
But I do agree with you. If you're just covering it up, but you should either notice that intraoperatively or postoperatively, they should have pain that's not in keep. One would think that they would have pain that's not in keeping with a normal patient following RBL.
Yeah, sure.
Yeah.
Okay. Thank you very much. That was a great presentation. Thanks.
Thank you very much. Appreciate it.
Okay, let's move on. Okay, and Ned, can you, for last name on my list here? Ned, are you there?
Yes, is the screen coming through?
Yep, the screen is there and I can hear you. That's great. Whenever you're ready.
Thank you. Good evening. I'll keep things brief. Thank you to the judges for giving up your time tonight, and thank you to the many previous presenters. This recently published study was a team effort, and I'm grateful to my co-authors, as well as to the multiple study funders, which included the college and the NHMRC. There is increasing recognition of the importance of patient-reported outcomes, and rightly so. How well do we know what matters to our patients? Indeed, consumer-centred care is the first of 3 pillars of safe and high-quality care as described by the Australian Commission on Safety and Quality in Healthcare. Patient-reported outcome measures have become common in general practice, general medicine, obstetrics, paediatric and psychiatry, to name a few. However, very few studies exist assessing patient-reported outcome measures in emergency general surgery. This is due to a slew of understandable difficulties. All admissions are by nature unplanned and frequently occur after hours. There's a heterogeneous range of conditions and patient numbers fluctuate widely. Patients are commonly in pain, nauseated and delirious and not well suited to complete questionnaires, and they move frequently from the ward for investigations or procedures. The emergency general surgery studies that there are tend to report objective data, such as complications, length of stay, and mortality. Those that report subjective outcomes have tended to describe the satisfaction of surgeons, trainees, emergency physicians, or even doctors' approximations of patient satisfaction estimated without their input. Only 3 studies to date have assessed in emergency general surgery the relationship between patient-reported outcome measures and aspects of their inpatient journey, and none of these have been from the Southern Hemisphere. Therefore, this study aims to identify factors associated with higher patient satisfaction in an Australian emergency general surgical setting. Methods. In this prospective study, eligible patients were consecutive adults admitted between the 12th of June and the 11th of July 2019 inclusive to the Royal Adelaide Hospital's acute surgical unit. Patients were invited to complete a validated questionnaire, either inpatient, in-person, in hours, or via telephone up to 4 weeks post-discharge. Patients were excluded if they declined or clinically unstable, lacked cognitive capacity, or were incarcerated. Questionnaires were administered by staff uninvolved in patient care, and patients were informed of this clear role separation, and the involvement was voluntary, confidential, and would not impact their care, nor be entered in their medical record. No inducements to participate were offered, and the study gained ethics clearance. The General Inpatient Survey is a validated questionnaire used in the United Kingdom's National Health Service for elective and emergency presentations. This study employed an abbreviated version of this instrument that has been previously used to assess patient-reported outcome measures in emergency general surgical patients in the Northern Hemisphere. Participants are asked for a list of 46 items, whether they experienced each of these items at all times, sometimes, or not at all. Finally, in question 47, patients are asked to rate overall satisfaction with their admission on a categorical scale from 0 to 10. Regarding statistics, responses are dichotomized using a previously validated top box approach, and multivariable regression analysis performed to identify items which remain significantly associated with improved satisfaction. To give you a taste, here's a sample of the questionnaire, which on average takes up to 10 minutes per patient to complete. Results. 146 consecutive adult patients were admitted to the ASU in the enrolment period and invited to participate, of which 100 or 68% were enrolled. Median age was 56 years and 48% were female. Compared to the patients unable to be enrolled, consenting patients had similar median age and proportion undergoing procedures, although fewer were female. After multivariate analysis, 8 items were significantly associated with increased overall satisfaction. These were age greater than 50, reporting sufficient privacy in the emergency department, satisfaction with the level of senior medical input, sufficient analgesia, important questions answered by nurses, confidence in decisions made about treatment, sufficient notice prior to discharge, and feeling well looked after. Conclusions and discussion. There is growing recognition of the importance of patient-reported outcome measures, and nationally embedded use of these have been recommended by Great Britain's National Health Service, much of Europe, and the United States of America's Food and Drug Administration. The Australian Commission on Safety and Quality in Healthcare is currently scoping means to adopt these practices and link them with funding. In our institution, this study has informed our efforts to improve the patient experience with various activities directed at the emergency department, nurses, or junior and senior surgical staff. In this study,
1 minute remaining.
Thank you. Factors associated with patient satisfaction were identified at multiple points in the patient journey. While many of these have been reported in previous similar studies, some differed. Hospitals should therefore assess factors valued by their specific emergency general surgical population prior to implementing initiatives to improve patient satisfaction. Thank you.
Okay, thanks, Ned, for that. Questions?
Thanks, Ned. You mentioned you had a 68% enrolment in the study. So do you know, well, I mean, obviously these kind of satisfaction surveys are quite biased against people that either love or hate their experience. So presuming this is going to take on a bigger role, what can you do to boost your enrolment rates a bit? Thanks.
I think this is almost the best case scenario. I don't actually think much better than this can be routinely obtained. The method we chose of having staff members attend patients as best as possible in person, and if they couldn't be made to perform questionnaires in inpatient, then calling them as an outpatient up to 4 weeks after discharge, that's pretty labour intensive. A lot of these patients either had short admissions where an adequate moment couldn't be found as an inpatient, and then they were either didn't answer the telephone, or we had inadequate contact details and couldn't contact them. We tried really hard. I wanted to get 90% enrollment, but we just couldn't get it. This is comparable and better than most of the previous similar studies. And as you can imagine, better than you might expect compared to, for example, mass emailing or mass posting, which are the previous methods.
Ed, I've got a question, and it relates to your conclusions based on the questionnaire. Thanks for an interesting presentation. What are your thoughts on the concept of patient experience and their experiences through the different parts of the hospital, contributing to their overall, feeling of whether they've had a good treatment or not. Because a general surgical patient will go through that acute assessment in the emergency department and then progress to the acute surgical unit. So their perspectives may be tempered by experiences in multiple different parts of the hospital. Could you comment on that, please?
Thanks, Marilyn. It's great to see you. That's exactly what we tried to tease out. When a patient is really happy or really sad, why is that so? And we tried to find a happy medium between asking them lots of questions and not overloading them with too many questions to try and tease out what mattered to them. And so we felt we did a reasonable job of teasing those aspects out. And it gave us some useful things to feed back, and we're able to have conversations with our colleagues in the emergency department and with our ward nursing staff and amongst our teams about the results of this study show that these things mattered. Let's go work on these things. The next step, I suppose, is going to be to repeat the study, which is our plan, and see whether anything has changed. Have our efforts to address what we think the study showed actually changed anything, and that's where we're heading.
Thanks.
Okay, thanks, Ned, for that. And that was the final question. That brings us to the end of this session of presentations. I'd like to thank everyone who has participated for the work they put in to what's been a really interesting evening. The recording will be put onto the college website, as Virginia outlined at the beginning. And for all who are interested, the next oral presentation in this series will be the webinar, which is on the Thursday, the 17th of September at 6 o'clock. So once again, thank you all for your participation and all the hard work you put in. And that draws this evening to a close.